Okay, so for chapter 19, this is blood. And so we're going to start by looking at red blood cells. But before we do, I'll just briefly go over what we already know. Okay, so we have test tube. Oh, that's a really awful looking test tube. Okay, and if you draw blood and you centrifuge it, you're going to find that there is, on the top we have the plasma, and the plasma is going to be about 55%, and then there's going to be a little buffy coat in here, and that buffy coat is made up of leukocytes and platelets. And then down at the bottom we're going to have the formed elements. We're going to have mostly red blood cells down here, and the red blood cells are going to make up about 45%. So that's kind of where we're starting out. We're not going to talk, we already talked about plasma in the in general A&P, and so remember plasma was mostly water, right? But then it also had some plasma proteins, and so there's several plasma proteins that we'll probably mention as we go along. Some of those plasma proteins are albumins. Albumins are the ones that create that osmotic pressure and kind of pull water back into the blood vessel. And fibrinogen is another one. Fibrinogens get converted into fibrin, and fibrin helps to form that blood clot. There's some other ones like transferrins. We'll talk about some other ones as we go along. But the plasma proteins are just proteins that are floating along in the watery matrix. Globulins. Well, yep, there's globulins for sure. Globulins, they can be carrier proteins. They can carry things around, but they can also be like immunoglobulins. So those are the main ones, but there are other ones like transferrins that carry iron around. So there's other different types of plasma proteins. It's just albumins, fibrinogens, and globulins are the most abundant of them, okay? Okay, so we're going to start now by looking at the red blood cells down here. So when you're centrifuging these, this whole area is going to look really red down here because it's packed full of red blood cells, right? Red blood cells' main job is to carry oxygen and carbon dioxide. So let's talk about a few different things about blood cells. First of all, in this chapter, you're going to have to learn numbers. You're going to have to memorize certain numbers for lab values. So red blood cells, there's a lot of red blood cells in your body. They make up about 1/3 of all your cells. So that's quite a bit when you're talking about, you've got trillions of cells in your body. There's about 25 trillion red blood cells. So that's not a number that you have to memorize, but that's just for you to see. That's a lot, right? So if we look at the red blood cell count, that's how many red blood cells per microliter of blood. All right, so we always look at blood in a microliters to see that's the volume. So in males, the average amount of red blood cells in males' blood is 4.5 to 6.3 million red blood cells per microliter, okay, or cubic millimeter. Either way, they're you can hear it either way. Okay, so that's in the male. In the female, then, the normal would be 4.2 to 5.5 million per microliter, okay? So you want to make sure that you're memorizing these numbers. There's going to be a few questions on the exam about it. One drop of blood is going to have about 260 million red blood cells in it. So they're really tiny, and there's an awful lot of them. Now, you do want to know about drawing blood, especially if since you're going into the health field. There's different ways that you can draw blood. One such way is called a venipuncture. And just like the name implies, you are drawing blood from the veins, right? So there's several reasons why it's easy to draw from veins and why we would do that. First of all, they're pretty superficial. They're close to the surface of the skin. They're easy to locate. You can see them pretty easily. And the walls are pretty thin, so it's easy for a needle to go through there. And the blood pressure in veins is pretty low. So when you do puncture it with a needle, it's not like blood's going to be squirting out, right? So it's fairly easy to draw blood through venipuncture. Another way, so you'd want to know why we would want to do that. Why would we want to use veins as a place to draw blood from? Okay. So second of all, we can get a drop of blood by pricking the fingertip or the earlobe, which is done in like infants, from the great toe or the heel or the fingertip. You know, those are areas where you can get like a drop of blood, and then you can use that drop of blood for a blood smear. And so that drop of blood is placed on a slide, and then you take another slide and slide it across. You get kind of a thin layer of blood, and then you can look at that underneath a microscope. And so we can use the blood smear to look at things like glucose levels. A drop of blood you can use to look for glucose levels or cholesterol levels. And with a blood smear, you can look at like hemoglobin and red blood cell counts. Okay, so that's a blood smear. Then finally, you can also draw blood from an artery, and so we call that an arterial puncture. And this arterial puncture, we're going to be looking at this more closely later on, not the actual puncture, but we do arterial punctures to get blood from arteries to look at blood gases. So we do a blood gas analysis. So when we start to look at chapter 27, and we're going to go over different things like acids and bases and things like that in the blood, we're going to talk about blood gas analysis to determine if someone has metabolic alkalosis or acidosis, respiratory alkalosis or acidosis. So we will be looking at that. The arterial blood gas analysis is usually looking at lung function. So we're trying to see how good is the lung functioning. And so to do that, we're going to analyze in the blood things like the partial pressure of carbon dioxide, bicarbonate levels in the blood, and pH of the blood. All right, so in addition to this, then, some other things. We want to look at hematocrit. Hematocrit is the proportion of red blood cells in your blood. Basically, what's the percentage of red blood cells in your blood, right? And so we really said in your blood it should be around 45%, but you're going to want to memorize the values for both males and females. So in a male, the hematocrit, or percentage of red blood cells basically, is 38.3 to 48.6%. Okay. And in the female, the hematocrit percentage will be 35.5 to 44.9%. Right? Again, you want to memorize those. So again, if we look at hematocrit, we draw our test tube here. Right? So up here we have our plasma, and I'll just leave that buffy coat out. Down here we have the red blood cells. So this is all red blood cells. Okay, and then up here, this is all plasma. So this is all fluid. So we have to look at this, and we have to say, well, what can change the hematocrit? Because this right here, this is 45%. This is 55%. That's what makes up whole blood. If a person were to be dehydrated, okay, if they are dehydrated, that means they're losing fluid. They're losing some of this water content. So that water content goes down. Now you only have this much. What happens to hematocrit in that case? If you lose this much fluid, and now you only have this much fluid, when we talk about hematocrit in terms of percentage, what happens to hematocrit? What happens to this number? Does it go up or down? It increases, right? You lost fluid. You didn't lose red blood cells. You lost fluid, so now the percentage of red blood cells go up. So hematocrit can increase with dehydration. Because you lost fluid, now the red blood cells are a higher percentage of what's left. Of what's left, the red blood cells is a higher percentage. What could decrease this percentage here? If you have overhydration, and you're absolutely right, if you have overhydration, then for sure, now that percentage is going to go down. That's one way. Okay, another way then is anemia. So do you guys know what anemia is? We're going to talk a little bit about anemia. Anemia is when you decrease the amount of hemoglobin or you decrease the amount of red blood cells, right? So if we were to decrease the amount of red blood cells, so we're decreasing the amount of red blood cells, what's going to happen to the amount of hematocrit? What's the hematocrit going to do then? Now you only have this much red blood cells. Hematocrit then decreases. Thank you. So hematocrit can decrease with anemia or, like what was suggested, overhydration. All right, so here's what our red blood cell looks like. You might remember that in general A&P we talked about how the red blood cell has this biconcave shape, and that's so that it allows it to have a lot of surface area, and you still have room for a lot of volume inside that red blood cell, right? So you have both of those. So it has this biconcave shape. It allows the inside of that red blood cell to be packed full of hemoglobin. Hemoglobin is the protein, and the inside of the red blood cell is made up of about 96% of the hemoglobin protein, okay? It also enables that red blood cell to stack up in like a rouleau formation where they are just stacking up together, one on top of the other. You can see them all here stacking up so that they can go through those tiny little capillaries single file, right? And that's good because we need the oxygen, we need it to be going slow so oxygen can leave the red blood cell and go out into the tissue, and carbon dioxide can leave the tissue and go into the red blood cell. So we need them to go nice and slow, nice and stacked like that in that rouleau formation. Now, one thing we know about red blood cells too is that, and this is a blood smear, so this is what you would see if you took just a drop of blood and then just kind of scraped it across a slide. All of these are red blood cells, and you can see it almost looks like there's a little donut shaped. That's not that is not open in the middle. That's just that it's thinner in the middle than it is on the outside. And you can see that there's no nucleus in any of these red blood cells, right? You can't see any nuclei in any of the red blood cells. So what do we do in the nucleus? A nucleus would make proteins, right? So number one, they would make proteins. So these red blood cells can't make proteins, so they're not going to be able to repair themselves very easily. So they're only going to live about 120 days. That's about it. The other thing that we have with these red blood cells not having a nucleus is that they can't go through the process of mitosis. So there's no stem cells. Red blood cells are not stem cells. The only stem cells for red blood cells are found in the bone marrow, in the red bone marrow. So red bone marrow is where these red blood cells are produced. Okay, so we'll talk a little bit about production in just a little bit. All right, so now we're going to talk about that protein that's inside those red blood cells, right? So inside the red blood cell, so here's our red blood cell. I'm not going to draw the shape of it, but inside here we have proteins that are called hemoglobin, right? And so hemoglobin, like I said, makes up 96% of the red blood cell. You have to know the percentage of hemoglobin, or the amount of hemoglobin in a person. So in a male, it's going to be different than a female. In males, hemoglobin numbers are 14 to 18 milligrams per deciliter. Okay? And in the female, the hemoglobin is 12 to 16 milligrams per deciliter. So you just want to know that those amounts. So each red blood cell then contains 14 to 18 grams per deciliter in a male and 12 to 16 grams per deciliter in the females. We'll discuss in a little bit, the differences between the males and the females in the blood. But anyway, hemoglobin, when we look at it, if you remember protein shapes, hemoglobin is a globular, it's a quaternary structure of globular proteins. So what that means is there are 4 globular proteins in one hemoglobin molecule. So like these are, 4 globular proteins. Okay, so that makes up one hemoglobin. And then at the center of the hemoglobin, we have a heme group. So this is a heme. And at the center of the heme group, we have an iron. Okay, so that's what a hemoglobin molecule looks like. All right, now that iron can bind to oxygen. So when the iron binds to oxygen, then we're going to call that an oxyhemoglobin, right? Oxy for oxygen, hemoglobin. And when that happens, the hemoglobin molecule looks like this bright red, right? Because it's binding to that iron. Now, when it doesn't bind to that iron then, and iron's not bound to it, then we call it deoxyhemoglobin. And at that point then, if iron's not binding to the oxygen, then the blood looks like a dark red. So this is how this is deoxygenated blood because it looks more like a dark red. This is oxygenated blood because it looks like a bright red. Now, there are a lot of these hemoglobin molecules in each red blood cell. So actually, each red blood cell contains about 280 million hemoglobin molecules. Right? 280 million hemoglobin molecules. And each hemoglobin has 4 of these heme groups in it. And so if we multiply that by 4, we can see that each red blood cell is going to have over 1 billion oxygen that it can bind to. So the point is, those aren't numbers that you have to memorize at all, but the point is that that's a lot of oxygen that one red blood cell can carry. Okay, so there is such a thing as fetal hemoglobin. Right? So fetal hemoglobin binds to oxygen more readily than adult hemoglobin does. So fetal hemoglobin is found normally in the fetus. So if this were the placenta here, and we had maternal blood on this side, and we had fetal blood on this side, the reason that the fetal hemoglobin has a higher affinity for oxygen is so that oxygen in mom's blood has a reason to go over to the baby's blood. So the fetal hemoglobin just has a much more higher affinity for that oxygen. Usually that fetal hemoglobin is going to convert to adult hemoglobin by the time the baby's born, or maybe up until the time the baby's a year old. But even in an adult can be given a medication to convert their adult hemoglobin into a fetal hemoglobin. And we'd want to do that in cases that when there's like a red blood cell disorder like sickle cell anemia, when the cells are not shaped properly and they're not holding enough oxygen, then we can convert the adult hemoglobin in a person with sickle cell anemia into fetal hemoglobin. So those drugs that can do that are like hydroxyurea, okay, and butyrate. Both of those convert the adult hemoglobin into fetal hemoglobin. So, hemoglobin carries oxygen, right? Hemoglobin carries oxygen. Well, at the lungs, the blood that's coming up to the lungs doesn't have a lot of oxygen in it because it just dropped off all the oxygen at the tissues. So at the lungs, the carbon dioxide levels are going to be higher and the oxygen levels are going to be lower, right? But any oxygen that you breathe in, hemoglobin is going to bind very readily to that oxygen at the lungs, which means that if oxygen levels are high, then the carbon dioxide levels are going to be low. And you're going to find this anywhere in the blood. Whenever oxygen levels are high, carbon dioxide levels are going to be low. Now at the tissues, then the exact opposite thing is going to happen, and we're going to see this more when we get to the respiratory system, but at the tissues are busy metabolizing. They're going to need more oxygen. So hemoglobin is going to release oxygen, and oxygen levels will be low, and hemoglobin will then bind to carbon dioxide, so then carbon dioxide levels will be high, right? It's just wherever oxygen levels are high, carbon dioxide is low. Wherever oxygen levels are low, carbon dioxide levels are high. Briefly, anemia. We did briefly talk about this. So whenever the hematocrit is low, if hematocrit is low, that's called anemia. Anemia can be caused from a number of different things. Maybe your hemoglobin levels are low. Maybe your red blood cell levels are low. That's hematocrit, if the red blood cell levels are low. Okay, that's an anemia. So if you don't have as much red blood cells or you don't have as much hemoglobin as you need to, the oxygen carrying capacity of your blood has gone down. Your blood can no longer carry the proper amount of oxygen that it needs, right? So if you don't have enough oxygen, your tissues aren't getting enough oxygen. And that means that you're going to have things like weakness if your tissues don't get enough oxygen, or lethargy. And if your brain doesn't get enough oxygen, then you're going to end up with confusion. So we need to make sure that people do not have anemia. We want them to have good oxygen carrying capacity. Okay, so the red blood cell gets produced in the bone marrow, and it has to take a trip around your body. It's going to go, when the heart pumps it out, it's going to go through all your arteries, down to your capillaries, back through your veins, and back to the heart. And that's going to take about 1 minute for the red blood cell. And while it's doing that, it's taking quite a beating. It's bouncing all over the place. It's bouncing against the edges of the blood vessels. It's bouncing against other cells. It's just bouncing along pretty good, and it takes a pretty good beating. And it doesn't have a nucleus, so it can't repair itself. So at the end of its life, that red blood cell the membrane bursts, and the contents, all that hemoglobin, is going to come out, right? It's all going to come out. Every day, there are about 1% of your red blood cells are going to be replaced, which means 3 million red blood cells are produced every second to replace the old ones. What we do need to know, though, is the process of red blood cell production, and we need to know the hormone that is going to control this. Erythropoiesis is stimulated by this hormone called erythropoietin. Erythropoiesis is the production of red blood cells. EPO is secreted by the kidney and the liver. EPO is also stimulated by testosterone. So what does EPO do? EPO increases your blood, right? So what about males? Males are going to have more blood than females, right? So that's where all of those numbers are always increased in the male, in all the normals that we've been looking at. We have our normal red blood cell count, and let's say that blood starts to drop. So your blood volume drops. or oxygen levels drop. Your body has to do something to raise those two things back up. And so as the blood is coming into the kidneys, there are cells in there that are going to recognize the decreased oxygen levels or the decreased blood volume, and the kidney then is going to release the EPO, or the erythropoietin. Erythropoietin is then going to travel to your red bone marrow. So if you remember where your red bone marrow is, in a lot of cases it's in the ends of the long bones, in the proximal ends of the long bones, or it's in flat bones, like in your skull, in your ribs, in your ilium, places like that. That's where red bone marrow is. And then the red bone marrow is going to release new red blood cells. And then your blood volume will go up again, right? So when we have low oxygen levels in our blood, we call that hypoxia. So erythropoietin will be released then with hypoxia. And erythropoietin actually has two different effects on the red bone marrow. First of all, it stimulates erythropoiesis. So it stimulates the release of red blood cells, right? Through erythropoiesis, the production of red blood cells. Then it also stimulates the maturation of the red blood cells, because those are the two things that have to happen. We have to produce the red blood cell, then the red blood cell has to mature very quickly. So EPO is going to do both of those things. EPO, when it is released, actually has a 10-fold effect on the red bone marrow, 10-fold. So normally where we had said that 3 million red blood cells are produced every second, 3 million now goes to 30 million red blood cells per second are going to be produced if EPO is present. Exogenous EPO can be delivered to a person, can be given to a person. Exogenous always means it's just coming from outside, right? So it's going to be injected, infused, however, that's exogenous EPO, and that can be given to a person who's recovering from a blood loss. Say they started hemorrhaging. They might be given EPO to stimulate their bone marrow to start producing more red blood cells and to help those red blood cells mature faster. If erythropoietin is given to a person who is already healthy and already has the proper amount of hematocrit, that's just going to increase the percentage of hematocrit, and their blood's going to get really thick. Well, if the blood is thicker, then that's going to make it harder on the heart. But sometimes athletes do that. You know, that's called blood doping, where they pull blood out, they separate the red blood cells, they store them for a while, and then in the middle of a competition, they'll inject them back into their body. Their blood is thicker, but it has a lot more oxygen that it can access, the muscles can access. So erythropoiesis requires a few things. Of course, it has to have iron, because iron makes up so much of, it makes, every hemoglobin has 4 heme groups, which have iron at the center of them. Amino acids, because that's what hemoglobin is. Hemoglobin is protein, right? It's a quaternary protein. And then vitamins B12 and B6 and folic acid are all necessary. So what do we know about vitamin B12? Okay, we know that vitamin B12, if you remember back to the digestive tract, vitamin B12 has to bind to intrinsic factor in order to be absorbed in the intestines. So if a person has sufficient intrinsic factor, they could possibly be given vitamin B12 as a supplement. But if they don't have proper amounts of intrinsic factor, it doesn't matter how much you give them orally, they're not going to be able to absorb it. So then what are you going to have to do with the B12? Inject it, right? You'd have to inject it. All right. So here we see, here's the old and damaged red blood cell, and here it is being phagocytized by a macrophage. It just engulfs it, brings it in, tears it apart. We have the heme group. The heme group breaks up into the iron. The iron is going to be transported back to the bone marrow where it can be recycled into new red blood cells. So that's what happens to the iron. The iron gets recycled. Then another component, the amino acids too, we talked about that. The amino acids here, they are going to also be brought back into the bone marrow where they can also be reused to make new red blood cells. So two things are getting recycled. Then we have another component that's called biliverdin. Biliverdin. Okay, biliverdin is when whatever's left of that heme group, the heme group is going to be converted to a biliverdin. And biliverdin, like the name implies, has more of a green color to it. And then biliverdin will be converted to bilirubin, and bilirubin has kind of an orange-yellow color to it. And then that will be released out into the circulation, and it'll travel all the way to the liver. So bilirubin gets all the way to the liver. Once it gets to the liver, then the liver is busy producing bile, and the bilirubin will bind to the bile and it will get excreted into the large intestine. Now, if there's a liver disease and that liver isn't working properly and you're not able to excrete that bile, what's going to happen to that bilirubin? It's going to stay in the blood, and then it's going to get stored like in the skin and in the cornea. And since it has that yellow color, what are we going to call that? That's jaundice, right? So when the liver's not doing its job and you're not excreting the bilirubin in the bile, it's going to get stored somewhere else, like in epithelial cells, in the cells of the cornea, and then you get this jaundice. In any type of liver disease, whether it's cirrhosis of the liver, fatty liver, hepatitis, anything that affects the liver, if the liver can't function properly, yeah, it's not going to be able to excrete that bilirubin. So it's going to end up going somewhere. It's going to stay in the blood and then eventually get stored in the skin cells and the cornea. Okay, but what happens to the bilirubin that is in the intestines then? Does it just get excreted then in the feces? Well, yeah. I mean, the bilirubin products are going to be converted into these two things. First, they're converted into an initial one called urobilinogens and stercobilinogens, but then eventually they get converted to urobilins and stercobilins. Now, stercobilins, that's what's going to make the feces have a brown color. The urobilins are going to be absorbed back into the bloodstream, and they're going to go to the kidney, and then once in the kidney, that's what's going to make the urine yellow. Okay, the urobilins. And then that gets excreted in the urine. So both of them are going to get excreted. Stercobilins get excreted in the feces, urobilins get excreted in the urine. Let's take a look at the iron real quick, and then we'll take a break. The iron. So the iron is making its way back to the red bone marrow, and most of the iron gets recycled. So you really don't need a lot of iron in your diet because not much of the iron will ever be lost in your urine or your feces. But there is such a thing as iron deficiency, like an iron deficiency anemia, and that's not good because if you don't have enough iron, then you're not going to be producing enough hemoglobin, right? You're not going to have enough hemoglobin, so you need proper amounts of iron to produce hemoglobin. And if you don't, then you're not going to have that oxygen carrying capacity of the blood. But on the other hand, if you have too much iron, then that can get stored in the liver. So iron can get stored in the liver, and it can also get stored in the heart. And so they've been linking a high iron levels with heart disease if there's an excess of iron in cardiac cells. All right, so now we're going to talk about white blood cells. And normal white blood cells, in 1 microliter of blood, there's about 5 to 10,000 white blood cells in 1 microliter of blood. Now that compares to 4.2 to 6.3 million red blood cells. So there's a whole lot more red blood cells than there are white blood cells, right? So when you're looking at a smear, you're going to see very few of these white blood cells. Okay. Most of the time, all of these red blood cells that you see here, at any given time, most of them are going to be in connective tissue proper. So that's adipose tissue, areolar tissue, dense irregular tissue. So dense irregular connective tissue is found in the skin. Areolar tissue is found in the skin. So there's going to be a lot of white blood cells in the skin. They can also be in organs of the lymphatic system. So they're just floating around out there in these different tissues. They're only going to be in the blood for a very short period of time. Actually, all the blood does is it transports them to areas where they need to be, where there is an infection. Okay? And so white blood cells are all going to have the same characteristics. They can all do the same things. First thing, they can all migrate out of blood vessels. So they can migrate out. And we call this ability to migrate out, that's called diapedesis. Diapedesis. They also have these amoeboid type movements, which allow them to move through your body tissues then. Through the different fluids in your interstitial tissue, they can move through those spaces through that fluid using the actin filaments. It requires ATP, it requires calcium, but at least they can move. So they can chase little bacteria through your fluids in your body. And then they are all attracted to chemical stimuli, and we call that chemotaxis. So when they're floating around in the blood and they get to an area where there's an infection, they, through that sense of chemical attraction, they're going to leave the blood right then and there, and they're going to go to where that infection is going on. So, all right, so we have that. We're going to look at the different types of white blood cells that we have, and there are some that are called granular, and there's some that are agranular. So granular just means that they have like a granular appearance. And from general A&P, you probably remember the different types that we have. All the white blood cells, we have neutrophils, eosinophils, basophils, monocytes, and lymphocytes. Okay. The ones that are granular are Ben. Okay, Ben. Basophil, eosinophil, neutrophil. The ones that are agranular, meaning they don't have a granular appearance inside them when you stain them, those are M and L, so monocytes and lymphocytes. So maybe that's an easier way for you to remember that, right? Ben are the granular ones, ML are the agranular ones. So these, the Ben ones, the basophils, the eosinophils, the neutrophils, and the monocytes, those are all part of what we call non-specific immunity. And when we get to chapter 22, we will be talking more and more about non-specific immunity. And then the other ones, the lymphocytes, those are part of the adaptive or acquired. So it's more of a specific immunity. All right, so let's talk first about these neutrophils. So this is a neutrophil right here. Okay, they make up the majority of the white blood cells. And actually, if you were to know the counts, if you wanted to know from highest concentration to lowest concentration of white blood cells, use the mnemonic, never let monkeys eat bananas. Neutrophils are in the highest concentration. Basophils are in the lowest concentration, so never let monkeys eat bananas. Let's start by talking about the neutrophils. Some key things you need to know about the neutrophils: they do make up 50 to 70% of the white blood cells, so they are the most numerous. They are highly mobile. They are the first to arrive at the site of an infection. The very first white blood cell to arrive at the site of an infection. They are going to digest bacteria, so they are phagocytic. They're phagocytes. They digest bacteria, and then they break it up. And when they break up bacteria, or they produce hydrogen peroxide. And this hydrogen peroxide forms pus. So wherever you see pus, you're looking at a lot of neutrophils. Neutrophils release things called prostaglandins. Again, in the immune system, we're going to talk more about prostaglandins, but prostaglandins cause inflammation. Neutrophils also release what are called leukotrienes, and again, we're going to talk more about those as well in the immune system. And what leukotrienes do is they call for other white blood cells, other lymphocytes to be there. They call the lymphocytes to be there. So they're basically saying, you know what, there is an infection going on here. I need those lymphocytes here now so they can identify what this infection is. That's basically what they're saying. But they have a pretty short lifespan. They'll eat about 1 to 2 dozen bacteria, and then they'll die. And then all that hydrogen peroxide they're producing then is going to get released when they die. The whole cell bursts, and then there you have your pus. Eosinophils. Eosinophils make up 2 to 4% of all white blood cells. Okay, they stain kind of a reddish color. They are also phagocytic, so they're phagocytes. And they engulf things like bacteria and protozoa. Okay, so protozoa, sometimes those protozoa are going to be too large and they can't engulf them. So in that case, they're going to release toxins which will affect the protozoa to kill them. Okay, they can also kill things even larger like flukes or worms. The other thing is that eosinophils are going to increase with an allergic reaction. Okay, so what they mainly are trying to do with an allergic reaction is they're releasing enzymes, and these enzymes are going to decrease inflammation. It's going to kind of it decreases the effects of neutrophils and mast cells, and basically what it's going to do is keep the infection local. It does that by releasing enzymes. And that's so that the you don't get a widespread infection. You just try to keep that infection very localized. The next ones that we have are called basophils. Basophils are the least numerous. They make up less than 1% of white blood cells. They release things like histamine and heparin. Histamine dilates blood vessels. What is dilating a blood vessel going to do? Bring more cells to the area, right? Bring more blood, bring more cells. Heparin then prevents blood clotting. So this sounds pretty similar to another cell that you remember, which is called the mast cell. So the mast cell is very similar, but a few differences are mast cells, they're not white blood cells, so they don't migrate. You know, those basophils, they're in the blood, and then they can get moved down to wherever that infection is, move out of the blood, move to the area. Not mast cells, they stay in certain tissues. And And the other thing is these basophils also release enzymes or chemicals to attract eosinophils and other basophils. So they're attracting other white blood cells. You see, these white blood cells tend to all work together, right? They're always trying to get their buddies to come to the fight. So basophils, they're a white blood cell. They're going to release chemicals to bring in more basophils, more eosinophils to help out with the fight. Mast cells don't do that. There's 20 to 40% of all white blood cells are lymphocytes, so they're second most numerous. And lymphocytes, we'll talk more about those when we get to the immune system. They play a big part in the immune system. You might remember we have T cells, B cells, and natural killer cells. And all of them are used to defend the body against pathogens. Okay, so we're not going to really talk much more about those today. Okay, then the last one is the monocytes. These guys are my favorites. I know, I forgot about my favorite one. Monocytes make up 2 to 8% of white blood cells. These things are huge. They're huge. They're spherical, they're very large. They're 2 times the size of a red blood cell, right? They're really big cells. They'll be transported in the blood for about a day, and then they leave the blood and they go out into tissues where they are called macrophages. The macro, the name alone tells you that they are big. They are most aggressive. They are very, very aggressive white blood cells. They will try to engulf things that are even bigger than themselves. That's how aggressive they are. They don't care. They're going to try to eat whatever they can. They'll eat up to about 100 bacteria or other cells before they die. You know, they're gonna engulf anything that looks abnormal. Doesn't matter if it's a bacteria or an infected cell or a cancer cell or whatever it is, it's going to engulf it because it looks abnormal to them. Then it's going to also release chemicals to call other white blood cells. Okay, and then they're also going to attract what we see in like skin damage, that they will attract fibroblasts, and the fibroblasts help to create scar tissue. Okay, but they are some pretty good soldiers. Okay, finally, with these white blood cells, we want to look at what's called a differential count. A differential count is where you're looking at the number of each type of white blood cell. So you're trying to see, you know, how many eosinophils are there out of 100 white blood cells? How many monocytes are there out of 100 white blood cells? So you're looking at the number of each type of white blood cell. So here's some terms that I want you to know. Leukopenia. Leuko, what do you think that means? Leuko means white blood cells. So leukocyte is the white blood cell. So leukopenia is a decreased or an inadequate number of white blood cells. So low white blood cell count. All of the white blood cell count is low. Another term is called leukocytosis. And this is an excess of white blood cells, of all the white blood cells. If leukocytosis gets extreme, we call that leukemia, and leukemia is a blood cancer. Okay? So cancers tend to occur wherever there are stem cells. wherever stem cells, because stem cells are producing new cells, and cancer is like producing abnormal new cells. So that's why, leukemia can be a disorder in the red bone marrow where those stem cells are that produce new white blood cells. All right, finally we get to platelets. We're going to talk about platelets and then hemostasis, and then we're done, right? So you guys are doing good. Platelets. Platelets are not actually cells. Platelets are cell fragments, and they are a tiny little piece of a bigger cell that's called a megakaryocyte. Megakaryocyte. So a little bit of the megakaryocyte pinches off, and then we have this platelet. And then these platelets are part of the clotting system. They're going to help with blood clotting. They're constantly being replaced. They only last about a week to 2 weeks, and then they're removed by the spleen. The spleen will remove them. About 1/3 of them are stored in the spleen. And then if you have any type of severe bleeding, they're going to get released in a massive amount so that you can help clot and stop that blood loss. So there's basically 3 functions main functions that platelets do. And one is that they create a platelet plug. So when platelets, we're going to see this process. I'm going to show you what this process looks like. But in the formation of a platelet plug, all the platelets are aggregating together. They're all clumping together. We'll sometimes call this platelet aggregation. Platelet aggregation. The second thing they do is that they will form the blood clot. So platelets mixed with fibrin, we're going to look at that process, but platelets plus fibrin form a blood clot. And then finally, the platelets, they are reducing the size of an opening in a blood vessel to stop the blood flow, but eventually that blood clot has to be reduced. And so that is clot retraction, where that clot starts to shrink in size. So the platelets are kind of involved in all 3 of those things, and we're going to take a look at those and see what that is. The process of producing platelets, and again, red blood cells, white blood cells, and platelets, they're all produced in the red bone marrow. That process of producing a platelet is called thrombocytopoiesis. Thrombocytopoiesis. Poiesis always means the production of. Lymphopoiesis is the production of lymphocytes. Thrombocytopoiesis is the production of thrombocytes, and thrombocytes are another name for platelets. Right? Okay, so during thrombocytopoiesis, that big cell that I called a megakaryocyte, that will produce about 5,000 platelets before it dies. 4,000 platelets. And then it dies. So it can produce a lot of platelets. A couple of things that will stimulate thrombopoiesis. There is a hormone called thrombopoietin, and that is from the kidney. So again, the kidney is receiving blood, and the kidney says, yeah, we need more platelets. Thrombopoietin gets released, and that's going to stimulate the red bone marrow to produce more platelets. Interleukins also will increase thrombocytopoiesis. Let's talk about hemostasis. Hemostasis is the process of blood clotting. Hemo means blood, stasis means stopping, right? Hemostasis. So we've heard about these phases before in general. The first phase is called the vascular phase. So you get a cut in a blood vessel. Here's your blood vessel, and you get a cut through the blood vessel. the first thing that's going to happen are those cut ends are going to spasm down and make that opening smaller. So we get, in the vascular phase, we get vascular spasm. Right? So that's where the ends constrict and they get smaller, so less blood can be lost. The other thing is that those ends get sticky. So if the ends get sticky, that means that those platelets then can stick to those little ends that are all sticky. So that's the vascular phase. That lasts about 30 minutes. Then we get the second phase, which is called the platelet phase. So the platelet phase, here we have the little platelets. We have little platelets, and the platelets get to those sticky ends, and they start to aggregate or stick to the sticky ends, and they form what's called a platelet plug. So that's going to stop. A lot of times, if it's a small enough blood vessel, that'll just completely stop that blood loss right then and there. And then the last phase that we have, that is called the coagulation phase. There's one more phase after that, actually, which is the retraction of the clot. But this phase is the coagulation phase. You know, we now have a platelet plug. Now, in this phase, we're going to form a blood clot. So there's two different pathways that this coagulation phase occurs. In the first pathway, so here's our blood vessel. The first pathway occurs outside of the blood vessel, and it's called the extrinsic pathway. This pathway is it's short, it's fast, it's first. Okay? Short, fast, and first. It happens right away. And in this phase, the damaged cells of the blood vessel are going to produce a factor called factor 3. Right? It's a blood clotting factor. It's a blood clotting factor. So the damaged cells are going to produce that. Then to enhance that, there's an intrinsic pathway that happens inside. And this intrinsic pathway is slower, but it reinforces the extrinsic pathway. And what it does is it is going to stimulate another blood clotting factor, which is called factor 7. So we've got two blood clotting factors now, factor 3 from extrinsic, factor 7 from intrinsic. Together, those two factors are going to stimulate the common pathway. All right, the common pathway is going to activate a blood clotting factor that's called factor 10. So factor 10 becomes activated. So this is just showing you the three different pathways. We have an extrinsic pathway, an intrinsic pathway, and a common pathway. And now finally we have factor X that's been activated. Factor 10, factor X, factor 10, blood clotting factor 10. This factor, this blood clotting factor, it is going to activate the conversion of prothrombin to thrombin. Thrombin then is going to convert fibrinogen to fibrin. So now we have fibrin. That's all we wanted to get to. What a long way to get there, huh? Extrinsic, intrinsic, common pathway, finally factor 10, converts prothrombin to thrombin, which converts fibrinogen to fibrin, and that's all we needed. We just needed fibrin. That was it. So what does fibrin do? So if you're looking at your blood vessel, and you have a cut blood vessel, and you have all of these platelets that are trying to stop the cut, right? Then the little fibrin just fits right inside all of those little platelets and forms a nice, hard, sturdy blood clot. That's why we need fibrin. All this clotting is going to occur within 8 to 18 minutes. You know from general A&P2 that this blood clotting is a positive feedback system. So as soon as factor 10 is produced, that's going to send positive feedback back up to the extrinsic and intrinsic pathway and make them produce more factor 3 and factor 7. So it just keeps going. Chemicals released are going to cause more chemicals to be released until finally we can stop that blood loss. So it's a positive feedback system. I want to talk to you about controls blood clotting. So blood clotting control. These are some things that you might hear out in the medical field. Okay? First of all, anticoagulants. Anticoagulants in the plasma, they inhibit clotting. Okay, so they prevent clotting from occurring. Anticoagulant. You might hear heparin. Heparin, we said, we said that it's released by the mast cells and the basophils, and they inhibit fibrin formation. Okay, so you're not going to, they prevent blood clotting by preventing the formation of fibrin. There's thrombomodulin and prostacyclin. Thrombomodulin. Thrombo sounds like thrombocyte. Modulin sounds like moderate. They break down fibrin strands. And then prostacyclin inhibits platelet aggregation. A drug that's very much like prostacyclin is called aspirin. So aspirin prevents platelets from aggregating. So aspirin is going to prevent blood clotting. Right? So aspirin is going to be contraindicated in someone that's going into surgery, for example, because you're going to want them to clot and for those wounds to heal. Thrombocytopenia. These are all big words, but you got to break them down. So thrombocyte means the platelets. Penia means low, right? Low. So we have low platelet count. That's low platelets. Hemophilia. Do you guys know what that is? It's a disorder where you can't clot, right? It's a genetic lack of those clotting factors. It's genetic. It's a lack of clotting factors. Another term is thrombophilia. Thrombophilia. Philia is loving platelets, right? Loving platelets. So in this case, this is a clotting problem. An example of this is a DVT or a deep vein thrombosis. Most of the time you find those in the legs. On occasion you can find them in the arm, but that's more rare, but that does happen. And then those clots in the venous system, that's what that's forming. Deep vein thrombosis, it's clots in the deeper veins. Those clots can loosen up and then they can travel to areas and cause lots of problems, like in the lungs, and then they cause what's a pulmonary embolism, right? Okay, that's fatal in like 30% of the time. So that's a deep vein thrombosis as it lets loose. Let's see, we need vitamin K. What do you think we need vitamin K for? To produce clotting factors. So without vitamin K, you can't even produce those clotting factors that we need. Where do we get vitamin K? Green veggies, grains, organ meats. That'll give you 50% of the vitamin K. The other 50% of the vitamin K in your body, the bacteria in your colon are going to produce when they are metabolizing your feces. Right? So 50% from diet, 50% from bacteria in your colon. Last thing we have, you guys are doing great, that final phase of clot retraction. Another name for this is called fibrinolysis. Fibrinolysis. Okay, so we have to break that clot down. The blood has to keep moving. If the blood doesn't keep moving, oxygen's not moving, and the tissues need oxygen. So we have to, as soon as the epithelium covers up that broken area of the blood vessel, we've got to get rid of the blood clot. So we have to go through this clot retraction. So there is a chemical called plasminogen. And plasminogen gets activated by other enzymes to become plasmin. And then plasmin digests those fibrin strands. Then the blood clot breaks up. Platelets are let loose, platelets circulate in the blood, and the blood clot's retracted. All right, so that's it for blood.